Thank you. Glad to be here today. I totally agreed on Dr. Lee's conclusion slide about post-COVID symptoms involves multiple systems, for example, cardiovascular, pulmonary, neurological system. This is actually a challenge for patients on how and where to get help, as they were already discharged from hospital and having post-COVID symptoms. Traditional rehab system, as you can see on the right, is divided into different specialties by body system. MSK, cardiopulmonary, neurological, etc. Now, rehab clinicians have the opportunity to practice a more holistic approach. At the beginning of pandemic, experts had warned about a tsunami on demand of rehabilitation for COVID survivors. And rehab associations around the world have published guidelines and exercise protocol for COVID recovery. However, there are still barriers when patients is back to community. Exercise intolerance is long COVID patients' biggest complaint. Therefore, when it comes to treating long COVID symptoms, it requires therapists to jump out of a traditional specialty framework and rethink how to use current clinical tools to help dealing with the symptoms more holistically. The purpose of this sharing section is to show you what in your clinical toolbox works with latest evidence support, and how to apply it safely on treating COVID symptoms. I have learned from a rehab professor from Israel in a WCPT webinar on COVID rehab. He said, know what you do and do what you know. The goal is to get patients back to daily life, back to community, and back to work. NMES is clinically proven and a standard of care on muscle rehab for most of the MSK indications. The NMES guru, Professor Get Along, published a review article in 2021, included 80 research papers, and presented on a recent webinar. He mentioned that NMES could play a key role in COVID rehab for muscle, but also works for vascular and respiratory dysfunction. The full webinar is available in the reference box. It's an open source, highly recommend. The key takeaways from his talk is that NMES is proven effective in weaning off patients from ventilators and should be continued in post-acute and longer-term phase of recovery. Rehab professionals should consider NMES to implement within Rehabilitation Pathway for COVID-19. Due to limited time today, I will share the 3 NMES protocols from Professor Alon. We have received more than 50 questions during the registration of this webinar, and most of them could be answered while we walk through the slides. In terms of NMES on respiratory indication, a physical therapist, Mr. David Yu, senior physical therapist from Queen Elizabeth Hospital, Hong Kong, he pointed out in 2010 the importance of early rehab in ICU. Otherwise, complications can delay the weaning due to the respiratory muscle weaknesses. A research in 2017, it demonstrated NMES for critical ill patients. NMES preserved the thickness of abdominal and chest muscles of critically ill patients. So this is an important foundation for further rehab. On the right is the protocol Professor Get Along recommended in his review articles. Here is the protocol. 2 times a day, 30 minutes per section, current intensity sufficient to activate muscle at exhalation. Current frequency at 30 to 50 Hertz. Pulse duration between 300 to 350 microseconds. Target abdominals, internal external obliques, intercostal muscle, and pectorals. I've made a short video showing the electrode placement, mainly targeting the TA. Let's take a look. Ask the patient to exhale when the steam is on. Inhale when steam is off. The program is set with 6 seconds on, followed with a 6 second off. Professor Alon points out the aim of this treatment is to synchronize activation of muscle during exhalation with patient's breathing pattern. Therapists can consider to use it for COVID patients with dyspnea. The application of NMES on vascular application has been overlooked for many years, despite the effect of NMES on muscle action and improving local systemic circulation needs no explanation. Stefano et al. 2016 has shown NMES acutely mobilize endothelial progenitor cells in critically ill patients. Also in the same year, 2016, Tanaka had also shown that NMES has a positive effect on endothelial function, which is highly associated with long COVID symptoms. NMES not only increases muscle strength, but also improves exercise capacity and the quality of life in patients with chronic heart failure. In the same research, Tanaka also shows that the NMES improves vascular endothelial functions to a similar extent as aerobic exercise, which AMI patients may have difficulty to perform. Same as some long COVID patients. Exercise intolerance, as we mentioned at the very beginning. Implication for therapists. NMES can be applied to patients with unstable hemodynamic status and autonomic imbalance because they can receive NMES therapy on bed without postural changes. NMES technology seems monotonous, but is the way the program decided make the difference. Let me show you how does the vascular NMES program work. Here is the NMES vascular protocol from Professor Alon. 4 to 24 hours a day, current intensity is sufficient to activate muscle action. Current frequency between 0.5 to 2 Hz, pulse duration between 50 to 560 microseconds. Target gastrocnemius or other big muscle group which can contribute secondary circulatory effects. Now, let's take a look on the video. This is a special program designed for facilitating venous return. We have 2 groups of electrode, group 1 on the calf and group 2 on the quads. Now we are going to start a contraction from the calf muscle. Now you can see the calf start to contract. And then we will have a co-contraction of the calf and the quads for another 3 seconds. This is a special program designed for facilitating venous return. We have 2 groups of electrode, group 1 on the calf and group 2 on the quads. Now we are going to start a contraction from the calf muscle. All right. Now, I do hope that you had a brief practical overview on the NMES applications for COVID patients in terms of vascular and respiratory dysfunction. Before I do a clinical conclusion, since blood clot is an important topic for COVID rehab, my colleague Anita Kwok and Novus clinical advisor will brief us on the evidence and protocol of DVT prevention using compression therapy for COVID patients. The background about Anita: she has over 15 years experience in cardiology, surgical instruments, and devices from various companies. She has provided many DVT prophylaxis training across Asia Pacific countries. Welcome, Anita. Exercise is medicine. This is also true for COVID recovery. However, recent studies point out that the biggest complaint from long COVID patients is exercise intolerance due to fatigue and dyspnea. This may be understood as poor compliance and discourage the patient to continue the treatment. Therefore, clinicians must demonstrate empathy by monitoring, measuring, and evaluation. This requires a different mindset and clinical considerations from clinicians. Italy, which was heavily hit by COVID, they had developed a full-body in-bed gym last year in order to address the long COVID symptoms, to facilitate the patient able to do exercise on bed, at home. And on the right, according to JOSPT this year, it highlighted the importance of stop, rest, and pace for long COVID patients in order to work within patient's limit. Let me share another experience from Singapore, Tan Tock Seng Hospital. The physio, she mentioned during an interview that COVID patient needs longer than usual time to go back to pre-morbid situation, and we cannot rush for the progress. She also recommends to use vital signs and PER to monitor training intensity. Empathy is especially important in rehabilitation of COVID patients. Peace and love. It is not something new to those audience who have joined our previous webinar series. This is an acronym for soft tissue management. And I personally think the love here is highly relevant for COVID rehab. Load, optimal loading. It was first published by Professor Glasgow in BJSM 2015. He reminded us that loading is not only mechanical, but also neurological and psychological. Together, they can produce optimal functional outcome. Same for COVID rehab. Optimism. Anxiety and depression are top symptoms of long COVID. COVID rehab journey can be unpredictable and episodic. Listening to patients with empathy, building on small improvement, try to create small positive feedback loop is essential to keep patients optimistic that they will get better. Vascularization is a key to push healing from inflammation stage to proliferation stage. Avoid stuck at chronic stage. When we apply rehab modalities, for example, NMES compression therapy for COVID rehab, we should always consider how to improve vascularization besides standard protocol for MSK. Exercise. Besides MSK exercise, consider breathing exercise and exercise to improve the heart and the lung functions. Exercise must be personalized, paced, and monitored, and most importantly, evaluated by a HCP. Thank you very much for your time today. I do hope that you find the sharing today useful. See you in the Q&A section. Thank you.
So, Stephen, we also know that, yes, there are physiotherapists actually specialize in dysautonomia or POTS management, especially special exercise that tailor intolerance. But they are far and few, I think. What is your experience and comment?
Yeah, thank you, Crystal. I believe that at the very beginning of my presentation, I mentioned that the traditional way of our system is a specialty. But, you know, when we are dealing with the COVID patient, because there is multiple system involved, and actually I'm not one of the specialty on the neurology. So for me, especially for those in the private sector, every challenge is an opportunity. And I believe that there is plenty of resources available online in treating POTS and related symptoms. So this is an opportunity for us as a therapist to equip with such a skill to capture, as I said, the tsunami of COVID rehab.
Yeah, that's great. So as mentioned in the intro, if the audience are interested, come back to our replay webinar. The replay webinar will actually link to the CDC webinar and the Cardiovascular Pulmonary Physiotherapy Association webinar in the USA together with this webinar. And as Stephen said, there are a lot of free physio courses for long COVID rehab available on the internet now. So challenge is also opportunity. I fully agree. Okay, so the next question, actually the next several questions are all for Stephen. So as mentioned, a lot of the people when registered are asking for the particular NMES treatment goal, protocol, electrode placement, and parameters.
Actually, the good news is that I have gone through those questions before I prepared the presentation. So that's why I believe that I had already described the details of the protocol of the 3 indications that Professor Glad-Alon mentioned. However, I still strongly recommend you to watch Professor Glad-Alon's full webinar, and the link will be available in the information box. And another thing I would like to point out is that for us, Chattanooga, we had a NMES therapy booklet, which include many different other indications of NMES, as well as providing with evidence support. It's a very good material, so if you're interested, reach out to our local representative. Crystal, you're on mute.
Sorry. So right now, there is contact button at the webinar that you can contact DGO and with local representative in your local language in Asia. Okay, so Stephen, the next question is also about NMES, but it's about how to choose different NMES devices. Do they have different clinical outcome, even based on the same protocol? What are the special considerations?
I have to be very careful in answering that question because I know that there are many physical therapists coming from the hospital authority today, and some of them may also be coming from the private. I believe that the mindset will be totally different. But most of the physical therapists, they will all know that an NMES, which is good or not, is to provide an optimal impulse in order to bring the minimum quantity of electrical charges to trigger an action potential. This is what we call the chronaxis. That means that the minimal intensity to bring the optimal muscle contraction. And recently, I have gone through one of the very recent study this year, published from Karolinski Institute. They were using the Chattanooga NMES device, which provide they found it provide the most comfortable steam. Some of the patients, they even have 0 pain score during having the stimulation, using what we call the muscle intelligence technology, with the minimal intensity to produce a target muscle contraction that gave the best outcome. And on the other hand, the other NMES setting, which they need to use a lot higher intensity in order to produce the same desired muscle contraction, that would cause a very uncomfortable feeling from patients. Those patients, they may experience like a 8 out of 10 pain score during the treatment. So this is a very, it's not desirable because the patient may refuse to continue the treatment. So different NMES device and protocol can have significant different outcome, especially when patients who never had NMES therapy before, and most of the time they are afraid of the electric shock or the pain. And as I mentioned in the presentation, NMES is not a rocket science, but it is the way the program designed to make a difference on patient comfort plus patient compliance. I hope that answered the question. You're on mute again, Crystal.
Sorry. Yeah, you answered very thoroughly. So since you mentioned NMES program and there is therapy book with all these different programs, I want to refer to what the JOSPT recently called out that for COVID patients who may be intolerant to exercise prescription, the stop, rest, pace. one of the biggest complaints of, again, young long COVID patient who only had mild and asymptomatic at acute stage. Months later, when they have long COVID, they can't do a lot of things they used to do. They can't even go back to work or to school. And that triggered anxiety and depression, especially in the younger active patient. So now they are told to stop and rest. You know, any other NMES program that could help them to during this dilemma?
Yeah, it's a very, very valid dilemma. On one hand, they are told to stop, rest, and pace, but on the same time, psychologically, they really want to improve, get back in shape, get back to work, get back to school. So our device, we also designed several recovery programs, which is mainly designed to relax and improve the recovery. Those are very low frequency programs, won't increase the vascular stress, and they can't do any harm. So the patient can do while they are resting or even on the bed. So I will recommend those low frequency programs for them so that they can improve the circulation. And my personal opinion is that if you improve your circulation, everything will get better because of the oxygenation.
Correct. So, okay, that's great that this program could provide help for these patients. So the next question is on NMES, but for a vascular condition. So as Dr. Lee mentioned in his presentation, myocarditis had a robust association with COVID-19. So it's an important complication, especially in pediatric population. So if we are going to use NMES for COVID rehab, is myocarditis or other heart condition a contraindication or sort of use with caution?
I believe this is a question because I just saw from the chat box, Jason, he is asking, is NMES contraindicated in patients with COVID-induced myocarditis? Now, to answer the question, I would like to bring up one of the papers that I mentioned in the presentation. Right. Tanaka et al. In his study, he focused on AMI, which is acute myocardial infarction. And it shows that in the study, a single section of NMES enhanced cardiovascular endothelial function without inducing excessive stress and autonomic responses. I believe this is a very good reference for long COVID rehab, since the vascular endothelial dysfunction is also strongly associated with poor prognosis with AMI patients. Preventing the exacerbation of vascular endothelial function is important for them to prevent the second episode of AMI. Although the aerobic exercise can improve vascular endothelial function, and everybody knows it, but it is difficult for AMI patients. And this is the same dilemma for long COVID patients. So therefore, the reason why I would like to refer to this paper is that if NMES is safe for AMI, then myocarditis is not a contraindication for NMES. But most importantly, if you have doubt, as Dr. Lee mentioned, check with the primary care doctors, cardiologists. You can do a trial section with related specialists. As I said, always monitor, measure, and evaluate. You're on mute again, Crystal.
Sorry. Yeah, so that's great for long COVID patients that even if they have heart conditions. So, Stephen, another question for you, since you are the dysphagia trainer across Asia Pacific, we know even at early time reported by Italy and Spain, a lot of long COVID patients also develop or have lingering dysphagia as a condition. So what could we help?
Right. Why so many questions for on that NMES? But anyway, Here, let me share my personal story. Being a physio for almost 20 years, my view on NMES have been restricted mainly on muscle only. However, there's been changes since I have become a trainer on Vital Steam, which is an NMES device designed to treat dysphagia, the swallowing difficulty. I've heard from many speech therapists, occupational therapists, that using NMES on swallowing muscle adjunct with swallowing exercise, even only after 1 to 2 sections, patient can swallow much safer and effectively. I believe most of you would agree NMES is not a magic wand and cannot improve muscle strength in just 1 to 2 sections. So what's the mechanism behind? There is always an area that we have been overlooked, is the neural part. Because from my view, muscle doesn't work alone. It's controlled by nervous system and our brain. And NMES may have the ability to reboot the whole system, to reset the connection between the brain and the muscles, and bring it back into normal function. Just like a computer hang-up that we deal with every single day, it needs a reboot. And there is a lot of new evidence showing NMES can be a neuromodulator to improve neuroplasticity. Therefore, I'm a strong believer on NMES is more than a muscle stim. And I believe this is also relevant to COVID rehab. I hope that answered the question.
Yeah, that you did. And also you also answered another question that several audience asked is how many session NMES can help to improve some of the symptoms. So as you mentioned, it's not only about the muscle, it's a neuromodulator, it improves neuroplasticity. So it could improve the symptom within just a few sessions, right? Depends on patient condition.
Yes, that's my experience because, of course, it's not a magic wand, but most of the time, once the system is being rebooted and then everything is going back to normal, just like COVID, if you do some of the assessment by system, they show no problem. But when it all comes into, all the pieces come all together, it doesn't synchronize. Just going back to what Professor Alon said, the reason why he would like to use the NMES for the breathing problem is that to synchronize the breathing muscles because they are not in sync. So that's why NMES can be a tool to connect the muscle back with the brain so that the brain can coordinate much better, just like what we call the motor control in MSK.
Right. Okay. We know that the physical impairment of long COVID will lead to mental health impairments and cognitive impairments. But as many physiotherapists here today, before long COVID, we also know physical improvement, exercise medicine that improve the exercise capacity will also help to literature show that it reduces 50% anxiety, 50% depression, and a lot of the even dementia, Parkinson's disease, a lot of the cognitive impairment. So this is our hope that we could help to improve long COVID patients, not only physical impairment, but also mental and cognitive quality as well. Stephen, what's your comment?
Yeah, I believe as a conclusion for what we shared today, everybody knows exercise is medicine, it's important. And the dilemma and the barrier for patient is the long COVID symptoms, fatigue, dyspnea. And we had already walked through the NMES for muscles, vascular, respiratory indication for today. With those improved, those 3 aspects improved, better breathing, better oxygenation, better exercise tolerance to overcome the exercise intolerance, to build this positive feedback loop. And in return, we should be able to improve the mental and the psychological aspect for those long COVID patients. And that's my takeaway. I will summarize by know what you do and do what you know and do what is work for patients.